Hi, everyone, and welcome. My name is Megan Hart. I'm one of the clinic partnership managers here at MAVEN Project. We're thankful that you're joining us today and our friends over at Clinica Sierra Vista for joining our chat on rheumatoid arthritis and osteoarthritis evaluation and management of the most common types of arthritis by Dr. Katherine Upchurch. Dr. Upchurch retired from UMass Medical Center, where she was the clinical chief of rheumatology for over 10 years. She is a professor of medicine at the University of Massachusetts Medical School. Dr. Upchurch's abiding passions throughout her career has been the care of patients with all rheumatic diseases and medical education. She has been a leader in the Massachusetts Medical Society and the American College of Rheumatology and was elected in 2017 to be an ACR Master. In 2015, the New England chapter of the Arthritis Foundation honored her with the Marion Ropes Award, given to one rheumatologist annually for their excellence in arthritis care. So with that, we're happy to have Dr. Upchurch, and I'll hand it over to you.
Great. Well, hi, everybody. The topic that I've been given is heroic. So I'm going to talk very quickly. Hopefully your ears can keep up with my discussion. And you've gotten the rules about asking questions. And if anything isn't clear, just jot it down and you can ask about it afterwards. I am going to focus more on the clinical aspects of both of these diseases as opposed to a detailed discussion of treatment, which is the subject of another talk. One other thing I wanted to mention, just so you'd be aware, this series of discussions or these rheumatology-based lectures was generated as a result of your request. And it's been really great to have a serial curriculum to talk about. And we have relied upon the services of other rheumatologists in the group. We have about 8, I think, now among the MAVEN volunteers. And last month, for example, you heard Dr. Gershon Bernard discuss laboratory studies. You're going to hear Dr. Fleischner discuss gout, and I will be discussing psoriatic arthritis, spondyloarthropathies, and a discussion of anti-rheumatic disease drugs, which will be largely focused on treatment of inflammatory arthritis. So that's what's coming up. Now we're going to get it to discussion at hand. The disclosures you're familiar with, the accreditation we've already discussed. The objectives today are to learn a diagnostic approach to evaluate articular, periarticular, and extraarticular sources of pain. Some of this will be a review compared to the from the talk that I gave last time to bring us all up to speed, and then we'll be launched. The second is to focus a lot on the distinction between inflammatory and non-inflammatory causes of joint pain based on history, physical exam, and diagnostic testing. I want to spend some time in particular introducing you to specific physical findings that separate OA from RA, and I'll from time to time use those two abbreviations to refer to osteoarthritis and rheumatoid arthritis. And then it's very important that you recognize when to initiate rheumatologic referral and understand why. So I'm sure you're aware from your own practice that there's an explosion of arthritis. These are some figures that I think give you pause. About 22% of US adults, or 50 million people greater than 18 years or older, report doctor-diagnosed arthritis. And the older you get, the more likely that is to be the case. And about 9% of these people have arthritis attributable activity limitations. So it's really important that we focus on this, even though it's not usually a disease that is fatal or progressive like malignancy or other diseases that you're also exposed to. Now, the word arthritis is the most common cause of visits to primary care physicians. Behind heart disease and cancer, it's the most common cause of medical disability. It affects young and old with significant economic ramifications. If you consider indirect costs plus direct costs, this is greater than $70 billion a year. Now, I wanted to remind you again, and this slide hopefully looks familiar, about the normal joint structure. And what you see here is a very fine, thin, single cell layer depicted by these little beads. And this is the synovial lining of the joint. It's very lacy and very fine when it's normal. And its job description is to make and enrich the joint with fluid. The synovium is the target tissue of rheumatoid arthritis, whereas the cartilage is the target tissue and where things go wrong with regard to the disease, which we call osteoarthritis. Now, when someone comes in and says, boy, I've got so much joint pain, doctor, your job is to determine whether this is due to tendons, where there's tenderness distant from joint structures but correspond to the muscle and the tendon, whether the pain could be neurogenic, that is, there's no tenderness at the site of perceived pain, and provocative maneuvers such as the straight leg raising sign that results in nerve stretch may lead to pain. And in neurogenic pain, the distribution is often related to a dermatome or a myotome and to the specific nerve root or the peripheral nerve that's involved. There are other mimics of joint pain, many of them. Vascular disease can cause low back pain and leg pain with ambulation, and sometimes it's hard to distinguish between vascular and neurogenic claudication. Paraneoplastic disease is a fearsome diagnosis to make, but it should be considered because arthritis can be a sign of early malignancy. And often you can have patients who come in who say they have shoulder pain, and actually it reflects referred pain from cardiac disease. I'm sure you all know that the most common extra cardiac manifestations of angina radiates down the left arm. But the key here is that the left arm is not painful when it's moved, and it's provoked by activity, strenuous activity, relieved by rest. Now, if you conclude when you think about those that in fact this is your patient's symptom reflects articular disease, there's some specific ways you can approach the history, which will, in my experience, probably 70 to 80% of the time, often lead to a pretty good, highly suspected diagnosis. And that is there pain on specific motions of the joint? Does the patient report erythema, warmth, or swelling? Which specific joints are involved? And what about the patterns of pain? So if you get the answers to those questions in a very focused fashion, you're going to have a pretty good idea about the fact that this is articular, but also some of the differential diagnostic possibilities. And that's really what I'm going to spend the next little while focusing on. So the overview is that there are many different types of arthritis, including inflammatory arthritis and non-inflammatory arthritis. Now, we use osteoarthritis as the prototypic non-inflammatory disease. And for the sake of discussion, we use rheumatoid arthritis as the most common inflammatory arthritis, perhaps save for gout, and as prototypic for a chronic inflammatory process. Now, there's plenty of mimics of those two diseases, and you'll see me mention some differential diagnosis as we go along. In two particular cases, and I've outlined these in red, rheumatoid arthritis and polymyalgia rheumatica, which can masquerade as RA, are important to consider early on, to exclude if possible, and if you can't exclude them, then you should refer the patient to a rheumatologist, because rheumatologists spend their post-residency training as well as their practice trying to distinguish these diseases. That's what we do. Now let's talk about the patterns of pain. If the pain is present at rest, this often is a true inflammatory process. If the pain is only with activity, it's very likely to be mechanical. We're not going to talk specifically about Charcot arthropathy, but it is a neuropathic problem, and patients can't feel their symptoms or any symptoms or pain, and yet they develop progressive deformity in the involved joint. So these are questions that you need to directly ask the patient and make sure you understand the answers. So I want to start off with one case presentation. This patient is SS. She's a 79-year-old woman in previously excellent health, and she developed the acute onset of severe polyarticular joint pain, hands, wrists, and then within a day or two, it had spread by her description, quote, everywhere, close quote. She was lucky enough to get in to see her primary care physician within a day. By the time she got there, she did have some generalized swelling, particularly of her hands and her wrists. And she had a variety of blood studies, which she was told were initially, quote, negative, close quote. And she had x-rays, which were positive for, she was told, quote, osteoarthritis. Now, at this point, there are a number of other questions that I'm hoping that you're thinking that you would want to know to try to determine whether osteoarthritis was in fact the correct diagnosis. This patient, we now know had articular disease because she told us. We asked her, and she told us which joints were involved. She had acute onset. How do we know that? She told us. So all we needed to do was to listen to her, and we're beginning to paint a picture. Was it present at rest? We asked that question, and she said, yep, sure is. Was it present only when she was weight-bearing? And this is the converse of the previous question, and the answer was clearly no. Did she have morning predominance? The answer was yes. And if someone says yes, it's important to find out exactly for how long. And she said basically well into the morning to midday, she was as stiff as she would ever be. And it barely got better in the afternoon. And she was severely, severely debilitated. And a patient with non-inflammatory arthritis, such as osteoarthritis, may say they feel as achy and stiff when they first get out of bed in the morning. And that's about it. It's within 30 minutes, but usually less, the involved joints get to be the best that they're going to be during the day. And in this particular case, we asked her, did you have constitutional complaints? And that includes fever, weight loss, fatigue, the other things that you think about with generalized disease, but particularly fever, fatigue, and weight loss. And at the initial presentation, she said no, but as her disease progressed, she clearly became more symptomatic. So based on the schema that I've already told you, I would say that it's pretty clear that this patient has, I'm hoping in your mind you're answering the same answer that I'm going to tell you, an inflammatory process. Because we've asked some questions that pretty much exclude osteoarthritis, especially the sustained morning stiffness. And I want to emphasize to you that listening to the patient often gives you the diagnosis. Sustained morning stiffness is one of the symptoms that I pay the most attention to. And constitutional complaints also are very important to me when I ask, when I'm seeing this patient. I also ask her other symptoms since I do think she has an inflammatory situation. So I want to know if she's had any viral symptoms or any exposure. Adult patients get parvovirus, for example, and can have acute polyarthritis. Or if she's had any foreign travel to places where chikungunya and some other viral illnesses that provoke arthritis have been endemic. And the answer to both of those questions was no. So we have a patient who has what we believe to be early inflammatory arthritis. And I will tell you that within, I said, a few days of onset of symptoms, she saw her primary physician. And I will tell you that we don't seriously start to consider chronic arthropathies until the patient has been symptomatic for at least 6 weeks. that's sometimes intolerable if the patient is having severe pain, but we don't really consider diagnoses such as these types of diagnoses unless the symptoms persist, with the exception of, say, gout, which is different. Although there is a pseudo-rheumatoid variety of gout that presents very much like rheumatoid arthritis. But if you see a patient and you pigeonhole her by talking to her within the first few interactions as having inflammatory arthritis, there is a differential diagnosis that should come to your mind. This is a limited differential. There are others for sure, but these are the most common things that I would think of. And again, remember, we're talking about inflammatory arthritis. Those include rheumatoid arthritis, lupus or related disorders. In an elderly person over the age of 55, polymyalgia rheumatica is a clear possibility. And there actually is a nice old paper that's in Arthritis and Rheumatism about PMR presenting as rheumatoid arthritis. And in that circumstance, you'd really want to carefully question the patient about headaches, jaw claudication, myalgias in the thighs and the shoulders. And if any of those are positive, you have to be very concerned that polymyalgia might be one of the leading contenders. Some patients, not all, a small percentage of patients with psoriasis have associated psoriatic arthritis. There also is a group of illnesses called reactive arthritis, and I'll be talking about those later. I will tell you that the incidence of psoriatic arthritis is less than the incidence of rheumatoid arthritis. And then there's the group of patients who have gout, but particularly what's called pseudo-rheumatoid gout that can masquerade as rheumatoid arthritis. And if any of you want to know some of my interesting case experiences in this regard, I'll be happy to tell you on another occasion or after this talk. We frequently see arthritic prodromes. For example, hepatitis B and hepatitis C often have generalized polyarthritis as a prodrome. And it's during that 6-week period while you're kind of waiting to see what happens to the inflammatory arthritis that these other diagnoses often manifest themselves. And they're, again, Lyme arthritis, which is not usually quite as generalized as rheumatoid arthritis or some of the other above diagnoses, but this might occur sometime anywhere 2 months to 6 months after a tick bite. But usually that involves lower extremity oligoarticular joints, that is not generalized polyarticular joints. So there's a lot to think about when you're talking to the patient, and within a very short period of time, you're going to have a good idea about what you think might be going on. I'm just going to give you an anecdote. I'm going to bring the above case presentation to a close and depart from it by telling you that SS actually was my first cousin. And she called me after I retired, and I took a history from her exactly as I'm advising you to do. And by the time I talked to her for 10, 15 minutes, in my mind, I felt that she most likely had rheumatoid arthritis. And by the way, I had asked her many other questions to exclude things like lupus, but it doesn't take long, and it doesn't take a heroic history to arrive at the correct diagnosis. So I don't want you all to underestimate what you in the clinic, when you're seeing for the first time, can ascertain about a patient's diagnosis. But I really do want you to focus on this concept, and you'll see at the end of the talk about why, in particular on the issue of inflammatory arthritis. Now, rheumatoid arthritis does often have clinical features that suggest an alternative diagnosis. I'm sure it will be relieving to you to know that I'm not going to read each of these lines, because that'll probably take 15 minutes in and of itself. The reason I put this table in was for you to read it and have it to refer to for future reference. So the idea is, if you have a patient that you think has inflammatory arthritis, look around and see if you can find some other explanation for polyarticular symmetric, because that is a feature of rheumatoid arthritis disease. And if you do, then you need to go down that path to see if you can exclude those alternative diagnoses before you come to the conclusion that the patient has rheumatoid arthritis. Now, if you have a patient who has generalized inflammatory arthritis, I think that the minimum of tests that should be done, and you heard about these last talk from Dr. Bernard, would be an anti-CCP, a rheumatoid factor, also inflammatory markers, SED rate, CRP, CBC, and liver function tests. Now, rheumatoid factor and SED rate are markers of inflammation, but they're not specific. A rheumatoid factor, particularly in low titer, as you learned last week, last time the rheumatologist had the forum, is often positive in older individuals, but the characteristics are that the positivity is fairly low titer. And in contrast, an anti-CCP is usually negative in older individuals. There are a few conditions that do have low titer positive anti-CCP, but the combination of a positive anti-CCP and rheumatoid factor, particularly in high titer, is pretty much a slam dunk for rheumatoid arthritis. Now, I typically don't encourage random, well, they've got arthritis, so I'm going to get an ANA because it must be lupus, or it could be lupus. If there are other features that suggest lupus, then an ANA can help you strongly suspect the diagnosis, and depending upon the nature of the ANA, might even confirm it. But I don't recommend general practitioners ordering anti-nuclear antibodies routinely because they're so difficult to interpret, and the incidence of positivity is so random, and it has a very low catchment in terms of picking up disease. It is unusual for a patient who has a negative ANA to have lupus, and the concept of ANA negative lupus is almost unheard of these days. So if there are a lot of features that do suggest lupus, get the ANA, and if the ANA is negative, well, then you better go back and rethink your diagnosis. But I don't recommend ordering ANA wantonly. Now, X-rays are, in the face of inflammatory arthritis, ordered for two reasons. One is baseline, because generally people with inflammatory arthritis have sustained courses. And so the baseline X-ray can be compared, and we'll see some examples of this down as the lecture goes on, to future X-rays, and the sum of the X-rays can be compared, and the change sometimes definitely confirms the diagnosis. But sometimes early on, X-rays will already have changes that suggest inflammatory, but particularly rheumatoid disease. And X-rays, if you do decide to take them, can distinguish rheumatoid arthritis from osteoarthritis, as we'll see. Talk a little bit about ACPA, which is another name for anti-CCP antibody. This is a prognostic marker, and it is associated with an increasing risk of developing RA. Interestingly, it is present up to 14 years before the onset of complaints. So just because you have a positive anti-CCP now doesn't mean that you've got arthritis, but if you do RA, but if you do have generalized polyarticular symmetric disease and a positive anti-CCP, it's highly likely that you have not only rheumatoid arthritis, but as shown here, poor prognosis rheumatoid arthritis that responds typically less well to aggressive treatment. It has similar sensitivity and higher specificity than rheumatoid arthritis or rheumatoid factor. Now, you may have heard about diagnostic criteria for rheumatoid arthritis. And again, just to bring you up to where we are, we've started with an overview of generalized musculoskeletal pain. And very quickly, I reviewed what I told you 2 months ago. And then we've used the history to separate inflammatory from non-inflammatory arthritis. And we're dealing with a patient who has a high likelihood of having rheumatoid arthritis. So the question is, we've got these antibodies, but they're negative. So what do we do? Well, first of all, we don't even apply any diagnostic criteria to a patient who's had symptoms for a month. we've got to wait until that magic 6-week sustenance of symptoms before we start really seriously thinking of rheumatoid arthritis. Now, in 1987, the American College of Rheumatology formulated what was widely referred to over the next 30 years, what was known as the American College of Rheumatology diagnostic criteria. The problem with those that people recognized back in the early 2000s was that those criteria diagnosed patients who had had disease for way too long. So some of the criteria were radiologic, that already had typical joint erosions and typical radiographic findings of advanced disease. So the idea was to come up with some diagnostic criteria that would allow clinicians to diagnose patients much earlier. And I actually participated in this. We about 20 of us from all over the world actually flew to San Antonio or Houston or someplace, and we were cooped up in some room around a large table. And we used statistical techniques to come up with some diagnostic criteria that we thought might work. And the diagnostic criteria reflect some things that make you think about what rheumatoid arthritis presents as. So look how frequently, look how strongly you get a score of the highest score possible if you have more than 10 joints, whether they're small or large, it doesn't matter. So diffuse polyarticular symmetric arthritis that is present for, that's present for at least 6 weeks starts out with a 5, with a cutoff point for RA as being greater than 6. In contrast, if you have one large joint, you're only going to get 1 point. And that makes it less likely that you're going to make it to what you believe is the cutoff point for RA. Now, if the serology is low positive, you get 2 points. If it's high positive, you get 3 points. And you can see that the combination of polyarticular arthritis, low positive or high positive, you are there at the cutoff point. Now, I don't espouse using these diagnostic criteria for every single patient, but it is interesting to apply them and to see where your patient falls, and it speaks to the nature of the disease, really. And so spend some time looking at these, and if you want to get a better overview of how we arrived at these criteria and how people are using them now, you can go to your library and look these up. The articles were in the Arthritis and Rheumatism at the time. I think it's now known as the Journal of Rheumatology or something. No, I don't remember what the new name is, but the point is that it's one of our premier journals, and also it was published in one of the European journals since there was a collaborative international effort to do this. Now, I think it's really important for you guys to understand this disease. So I'm going to quickly whisk you through rheumatoid arthritis. So you have this lady, she's 75 years old. She comes in, she has polyarticular symmetric disease. Actually, I think she was 78 or 79 when she called me. And the question is, what do we expect? Or even more important, when you have somebody who is in their 20s, 30s, 40s, what do you expect when you diagnose RA? Well, it is a chronic systemic inflammatory disease. It's characterized by progressive destruction of cartilage and bone in potentially all synovial line joints. It's not clear why some are involved in some patients and some are involved in others. And it's true that it can skip the shoulders, but be terrible in the hips and knees in some patients. It can skip the hands and wrists or prominently in the hands and wrists. But it does involve many joints. The disease damages ligaments and tendons. It results loss of physical function, quality of life. It is associated with disability and underemployment, extra-articular involvement. And also, it's important to realize that rheumatoid arthritis, although itself is not a fatal disease, it's associated definitely with decreased life expectancy. Now, the epidemiology is the prevalence is 1% in various ethnic groups worldwide. There are 1.5 million people in the United States who have rheumatoid arthritis. Now, we'll contrast that with osteoarthritis in a moment. The female predominance is 2 to 3 to 1. The variable age at onset peaks around 25 to 45, but it can occur at any time. And as you see, my cousin, who was nearly 80, was presented initially with the diagnosis of rheumatoid arthritis and with signs and symptoms and findings that substantiated that. There are genetic associations that I put down for you here that are interesting. And this is the immune locus, HLA-DR4. All of these, in fact, are immune loci. And rheumatoid arthritis is an autoimmune disease, and the anti-CCP and rheumatoid factor are manifestations of that. Now, this is a patient with generalized swelling of the PIP joints, and you get the sense by looking at this, PIP, proximal interphalangeal, which is the middle knuckle. You get the sense that if you sort of palpated it, it would feel kind of squishy. And yes, that's true. But I want you to notice that there's no involvement whatsoever of the DIPs, which is typical of rheumatoid arthritis. And if you hear, there's not too much involvement of MP joints. Now, MP joints and PIP joints, as far as the hands are concerned, are the most commonly involved joints. The other thing about this disease is it routinely is symmetric. So polyarticular symmetric disease is the nature of the beast. And if you think about it, you have 5 fingers and you have 2 joints on each finger that typically are involved. So you reach 10 joints in that previous diagnostic criteria by just having both hands involved, not counting the wrists, the elbows, the shoulders, the hips, knees, ankles, toes, the jaws. I mean, any joint that has synovial lining can be involved. Now, of concern is the fact that there's very early radiographic progression as depicted by this slide. And this is a schematic of what happens over time. This is within the first 2 to 5 years of disease. This is a normal joint. This is a joint with early erosions, and see the x-rays that are paired. And this is a joint with much more evident erosions as a result of progression of disease. And we can see that in the joint count, the erosion count, and the deformity count. 67% of patients within the first 2 to 5 years who aren't treated will develop that. This is a very early recognized fact. This is another set over the space of about 15 years of normal joint space, early progression of erosion. You can see it right around in here and over here, and then obvious involvement here. And these are the MP joints, or actually the PIP joints, I'm sorry. Oh, nope, MP joints, it tells me right here. And so these are progressive with time. So the fact of the matter is, if you have a patient, 30% have erosive disease at the time of diagnosis, another reason to get x-rays. 60% have erosive disease within 2 years, and a delay in treatment by as few as 3 months after diagnosis can be associated with increasing radiologic damage up as long as 5 years. You do reset that timeline if you go ahead and start treatment within about 2 years. And again, a brief delay of therapy affects the progression of structural damage. You can see early treatment, delayed treatment. This is delayed treatment, and this is early treatment in terms of the SHARP score, which is a way of measuring erosive disease. Now, if you don't have effective treatment, even if you're trying to treat the patient, but you've not been lucky, or in my case, you were practicing rheumatology before there were any progression of treatment, you may end up with a patient who has polyarticular symmetric disease and profound deformities such as this. This is interosseous wasting. MP subluxation and synovitis. There's nothing else that can look like this. This is what's called a Z thumb. These are typical rheumatoid deformities. Let's see. And in the very end stages, you can get marked ligamentous laxity, and this is called telescoping, which I hope we won't see this ever again, and we'll discuss that. But some patients are resistant to treatment, and I've seen, sadly, patients that I can't talk in to being treated, and that's unusual. And they are definitely at risk for progression of disease. And it happens very subtly. You know, you may think that this is something that, oh, well, surely your rheumatologist can pick this up, that it's happening. But if you see the patient twice a year, or even the patient skips an appointment and doesn't come back in for a year, and they're just stuck on one drug and don't complain, it's easy for these types of things to happen, but hopefully they don't happen much anymore. Now, these are the x-rays that correspond to the patient with the MP subluxation. You can see there's marked periarticular osteopenia, marked erosive changes. They look like little rat bites is how they're described. And interestingly, look up here, you see some osteoarthritic change. You see the little node here? That is not related to the underlying rheumatoid disease. That is a change of osteoarthritis. So you also see MP loss of joint space and narrowing, and this is advanced disease. There are other joints that are involved. This is the case of the hips. I want to call to your attention that in osteoarthritis, the hip disease is along this axis here, the superior joint line. In rheumatoid arthritis, it involves the entire joint, and you can see that well over here too. So both of these are involved in entirety not in a north-south point of view or orientation. A lot of cystic change, a lot of acetabular sclerosis, demodeling of the femoral head, etc. Now, this is a patient who came in with year 0 when rheumatoid arthritis was originally diagnosed. She has some early degenerative changes with peaking of the tibial condyles here, but the joint space is normal and there's no erosive change. She didn't get any treatment, and at 8 years, paralleling that hip x-ray that I showed you, she has diffuse joint space narrowing, which would be atypical of rheumatoid of osteoarthritis, also, which is commonly involves the knees. So there is no weight-bearing line of involvement in rheumatoid arthritis. The whole joint is involved, and that's largely, as you can see when you think back on that slide of the fine synovium that involves the whole joint. There's no reason for there to be preferential involvement of certain parts of the joint, because the entire synovium becomes almost like a villous tumor and eats away at the cartilage and the bone in a very symmetric and diffuse way. Now, this is a patient who has MP subluxation of the feet, and you can see cock-up deformities and all across the MP joints. So I wanted to show you just a smidgen and a sampling of involvement of many joints in patients with rheumatoid arthritis. I've got hundreds of pictures that I could have chosen, and this is just a very random few. But what I was seeing at the end of my practice, much more so than these, was much less obvious disease. And that really reflected the fact that with the advent of aggressive disease-modifying treatment and early diagnosis, and especially the advent of biologic treatment, we don't see the kind of advanced disease that I'm exposing you to quite as much. It's not just the joint disease, though. As I said, rheumatoid arthritis is a systemic disease. Decreased life expectancy, increased comorbid illness, It is definitely associated with increasing and premature heart disease. It's also associated, sadly, with uh, severe consequences from treatment-associated infection and also treatment-associated tumors. So lymphoma now is pretty much felt to be an unusual but nonetheless recognized complication of anti-TNFs as well as other serious diseases. Now, one example of extra-articular manifestations of rheumatoid arthritis is the rheumatoid nodule. Now, a rheumatoid nodule presents in many different areas of the body, but characteristically over the extensor surfaces of the forearms. And this is said to be associated with a very high titer positive rheumatoid factor. Not only are rheumatoid nodules in the periphery, but they also can occur in the lungs. And this basically, they look like cannonballs, little bitty balls. And the only way to distinguish this from cancer or from, say, Wegener's granulomatosis is to go in and do a wedge resection and look carefully at the pathology. And when you see the pathology, you see the pathology of typical rheumatoid nodules. We also see in the lungs a high incidence of interstitial lung disease as reflected by this X-ray and these CT scans. And this is a very feared complication because it doesn't necessarily regress with aggressive treatment, corticosteroids, or even anti-TNFs. And this is associated with, again, the high titer rheumatoid factor positive, anti-CCP positive disease. Patients can have a variety of different ocular involvements. This patient had episcleritis, but also you can get scleritis, thinning of the sclera, and this is the advanced stage of that, which leads to scleromalacia perforans. Now, these are, again, advanced cases of disease that have been present for many, many years. We just don't see that as much anymore. And I'd like to think that the biologics have made a major difference because we do see that disease activity is suppressed by many, but not all patients on biologics. Also, you can see peripheral vasculitis in rheumatoid arthritis, and these little black areas are tiny little infarcts associated with cutaneous vasculitis. You can see them all over the place. And in the worst case scenario, and I've actually seen this, you can see distal gangrene from complete occlusion of the arteries that supply the distal digits from vasculitic involvement. And there you can see a typical lesion and typical necrosis here and here. So because of a combination of the recognition of rapid progression of joint disease and also the possibility of systemic disease, the American College of Rheumatology recognized that this disease needs to be diagnosed and treated early. And that further now we know that there is a critical window of opportunity to, in many cases, actually bring the patient nearly into active remission or to disease remission. So the goal of treatment is to arrest the disease and achieve remission. But if it's established or if it's end stage, we're not going to be able to do this. So this is the critical window. And I really want you to take that message home if there's any message. And that is that if you have a patient with rheumatoid arthritis that you strongly suspect, that patient needs to get in to see a rheumatologist ASAP. And so many people say to me, I can't find a rheumatologist. And actually, I would argue that there's not a rheumatologist in practice, or if they are, they shouldn't be in practice, who, if confronted with the notion that a patient has early onset, likely rheumatoid arthritis, wouldn't add in a patient just to see the patient for 15 minutes and see if he or she agrees and then work her into the schedule in the next few weeks after that. There are ways that these types of patients can be presented to to specialty physicians to sort of get them to make room. And these types of data, I think, really compel the argument that this disease needs to be treated and it needs to be addressed early. And you guys are the first gateway for recognition of these diseases, these patients with this disease, and of separating these patients from just simply end stage or early or end stage osteoarthritis. Now, I'm not going to go any further than this with regard to rheumatoid arthritis. I mean, I could talk for a lifetime on it. But what I really want to do is to spend a very few minutes contrasting what I've told you about rheumatoid arthritis with some of the things we talked about with regard to osteoarthritis. And I think at the end of the day, this will underscore the conclusions of this talk, and you'll agree with my take on rheumatoid arthritis versus osteoarthritis. So this is another case presentation who also happens to be a friend of mine. 75-year-old vigorous woman in excellent health. She had a gait disturbance due to progressive knee pain and deformities without other joint symptoms. She had pain only with ambulation. She had less than 30 minutes of morning stiffness. She had no systemic symptoms, no other joint symptoms. And the exam showed a severe right greater than left knee valgus deformity with some effusions. There also was DIP and PIP, non-tender bony swelling. Now, what's your diagnosis? What do you think this might be? And I'm sure that all of you got it right. And hopefully this case, when presented in contrast with my 78-year-old cousin, patient SS, really shows a lot of differences that would make you really go down the path toward the correct diagnosis. So the symptoms in osteoarthritis: mild swelling, joint pain, the particular involvement, knees, hips, synonymous with rheumatoid, but the x-rays look different and the other associated symptoms are different. Thumb, distal hand joints, that is, the PIPs overlap and the DIPs are not involved by osteoarthritis. These diseases, patients with this disease have clear-cut weight-bearing pain. And if they sit down, it is absolutely much better. The symptoms rarely are acute, although sometimes you can have flares. They usually are subacute to chronic and very slowly progressive. And again, no systemic complaints, no unexplained fever, fatigue, malaise, sweats, and they have less than 30 minutes of morning stiffness. I often would ask a patient, if I were to take away your X pain, let's say they came in with knee pain, if I were to take away your knee pain, how would you feel? Robustly, patients with osteoarthritis would say, great. And a patient with an inflammatory form of arthritis, particularly rheumatoid, wouldn't feel so good because they have a systemic disease. Now, just to remind you, I'm not going to spend much time with this, but the cartilage is the problem here. And it's thinned, and the bone ends start to rub together. There's not this padding here, and it does not involve the synovial membrane, which is here. Osteoarthritis is the most common form of arthritis. And if you took x-rays of 70% of patients over the age of 65, they're not always symptomatic, but they've got osteoarthritis of the knees. Now, unlike rheumatoid arthritis, which you probably won't see too much of, I would bet maybe a case every year or two, you're going to see a lot of osteoarthritis. So there are estimated 32.5 million patients in the US, and it's getting more because we're all getting older. Unlike the rheumatoid, when I told you it was about 1.5 million patients. And it is the leading cause of pain and disability in the elderly. Other names for it: wear and tear arthritis, degenerative arthritis. Oddly enough, most lay people think that, quote, arthritis is osteoarthritis. And they think that all I did with my career was take care of people with osteoarthritis because that's their frame of reference. Now, the American College of Rheumatology plus others basically think that tests and even x-rays are not usually needed to diagnose OA, I'm sorry, OA. Because if it walks like a duck, talks like a duck, quacks like a duck, it probably is a duck. So if you see a patient with one joint involved, severe valgus deformity, progression of disease, no morning stiffness, no systemic symptoms, probably it's going to be osteoarthritis. If you order a rheumatoid factor and you find that the rheumatoid factor is positive, it's going to confuse the diagnosis. And x-rays, however, can substantiate the diagnosis. So, I think if you're interested to see what the x-rays show, you certainly can. If you send the patient to an orthopedic surgeon, he or she will get x-rays to sort of see what the baseline is. But you can pretty comfortably say this patient has osteoarthritis, and you don't have to call a rheumatologist and beg and plead and get on your knees and say, you got to see this patient tomorrow. You might want to have that rheumatologist sign on and follow the patient with you to help with the very, very challenging decision-making process of when a total joint replacement is called for. But that's a whole nother can of worms, and it's really not the focus of this talk. So I certainly spent a lot of time doing that, and it's helpful to have more than one set of eyes and ears in that regard. Now, I wanted to bring up the concept of secondary osteoarthritis because someone in this group 2 months ago asked me about this. I didn't really focus on this too much before, but there are a lot of causes of secondary osteoarthritis. And I'm interestingly notice if you have inflammatory arthritis, let's say in your wrist, 10 years from when that inflammatory arthritis was the worst, you may have secondary osteoarthritis. So you have both secondary osteoarthritis and have had rheumatoid arthritis for years. And that's not uncommon. Doesn't mean you don't have rheumatoid arthritis. It just means you have secondary disease. And then the question last time was about hemochromatosis. And so these endocrine and metabolic diseases do cause joint-based problems and do affect the cartilage as well. Now, I have no idea what Cauchy-Beck disease is, or I can't even pronounce this disease. Someday when I have time, I'll look those up. But we've gotten away from using these types of names, and also they couldn't be very common because I've never heard of them. Hypermobility syndromes, in contrast, are often seen and do cause a lot of problems, as do the mucopolysaccharidoses. So, this is something that should be considered. Sometimes, depending upon involvement, interestingly, with hemochromatosis, you get involvement of the MP joints diffusely, even though the changes are more osteoarthritic in nature radiographically. And there's some characteristic hook deformities that you can see on x-ray to lead you to suspect that. And it's pretty important if you see a patient and suspect it that you test for it because it's familial, and you would definitely be likely to find some other carriers or even affected patients in a patient's family if you did check for it. So this is a patient with osteoarthritis. You can see this is called a Bouchard's node when the PIP joint is affected. These are Heberden's nodes, hypertrophic changes, cartilage loss, and then notice that the MP joints are spared. This is a patient with medial joint space narrowing. Again, medial joint space narrowing. So this is localized disease as opposed to that generalized disease I showed you before. And this is osteoarthritis of the knee. And you also obviously can get lateral compartment disease as opposed to medial compartment disease as well. Here is a patient with lateral compartment disease and severe medial compartment disease, both of which are osteoarthritic. You can see they're well-preserved cartilage in other parts of the joint. I just wanted to run this by gender, age, race, genetic predisposition. All of them are non-modifiable risk factors. There are a lot of modifiable risk factors that I took the slide out because I knew I'd be running out of time, but weight is a big one. And they're genetic, they're modifiable things like if you play pro basketball, you're going to end up with injuries that lead to osteoarthritis, etc. So I'm going to sum it up by giving you this slide to go home with and to study and put under your pillow. These are separable diseases, and we talked about all of these differences between the two. This is another way that you can sort another slide depicting the differences between the two. This is a patient with PIP joint involvement and DIP joint involvement. So what do you think would be the diagnosis here? Just, do you think this is rheumatoid arthritis or osteoarthritis? Anybody have any ideas? I know I can't hear you, but I'm guessing that most people, because of the DIP involvement and the PIP involvement, said, oh, this is probably just osteoarthritis of the hands. Well, just so you think, so you don't think rheumatology is always easy, this actually is rheumatoid arthritis with rheumatoid nodules, which are extra articular on top of the joints. So this is a rheumatoid nodule, rheumatoid nodule, rheumatoid nodule. And I have one patient who just, he's had hundreds of rheumatoid nodules surgically removed, and within a few years, they always come back. But he likes that time when he doesn't have them, so he just goes and gets them renewed, gets them removed. Conclusion. So if you have a patient in whom you suspect inflammatory arthritis, listen to the patient, ask the right questions, and see if you can come to a high degree of suspicion that the patient does have inflammatory arthritis. If it's inflammatory, are there features suggesting underlying alternative diagnoses? The main thing I want you to take away from this is osteoarthritis and rheumatoid arthritis are separate disease entities. Now, I haven't given you a comprehensive overview of osteoarthritis, and there's a huge body of literature looking at genetic cases of osteoarthritis, looking at causes, looking at treatment, probably as much or more than even rheumatoid arthritis, but they are separate diseases entirely. There definitely can be overlap, as mentioned here. Advanced RA may lead to secondary OA. Now, this is very important. Delayed diagnosis may lead not only to polyarticular joint destructive arthropathy, but potentially severe systemic disease. So, if you have a patient in whom you suspect inflammatory arthritis, early rheumatologic referral is really important. You may want to get a rheumatologist to help you with regard to osteoarthritis, because osteoarthritis of the knees probably does respond to frequent corticosteroid injections, no more often than every 3 or 4 months, but for some period of time. And that might be something that you wouldn't want to do. You'd want a rheumatologist to do it. But bottom line is the rheumatology bread and butter is to take care of patients with inflammatory arthritis, particularly rheumatoid arthritis. Now, this is a plug for my talk on anti-rheumatic drugs, which is going to be, I don't know, in a couple of months. So watch your calendars and watch the announcements and come join me then. And with this rapid race car approach through a very large part of rheumatology, I will stop and see if anybody has any questions.
Thank you, Dr. Upchurch, for that wonderful educational session. I know we're at time, everyone, but if anybody does have questions, I want to open the floor up. You can use the Q&A box, or if you'd like to speak directly to Dr. Upchurch, just raise your hand and ask to unmute, and I can unmute you. So I'll give a few minutes for everybody if anybody wants to ask questions. Just a reminder for the CME survey, it will appear in a tab as soon as you close out of this webinar. Again, if you missed that, you will receive an email link to that tomorrow within 24 hours.
And Megan, if anybody has to leave, they can write the questions down and send them to you, maybe, or send them someplace, some email address, wherever they send the forms.
Yeah.
And then you can send them to me. I'll answer them. Okay.
Perfect. Okay. We do have one question here. Let me bring it up. It says, while patients are waiting for rheumatologists, what's the best treatment to start for RA?
Well, that's a great question. I always probably, if there are no contraindications, would start with an anti-inflammatory drug. But I've had patients, including my cousin, who simply was so dysfunctional that I would start with a low dose of prednisone. Now, you don't want to do that randomly and thoughtlessly without seriously considering the ramifications. But if they're symptomatic enough, that should tide the patient over until they get to see a rheumatologist. You can even do a Medrol dose pack. Just get a pack and tell them to take it as directed, and that'll take the edge off of it.
Hopefully answered the question. I don't see any other questions, but like Dr. Upchurch mentioned, if you guys think of any questions or didn't get to add them in the chat and are having to hop off, then just email them to me or the programs manager, Kristen Talbot, who has been in correspondence with you all, and we will gladly send them to Dr. Upchurch. But with that, I don't see any other questions in here. So thank you all for joining, and we hope you have a great rest of your day. And thank you, Dr. Upchurch.
Sure. And thanks for coming. I'll see you guys in a couple of months, or maybe next month. I don't know. I'm not sure.
Yes, be on the lookout for the next talk. All right, goodbye.